Good day, everyone. My name is Casey. I'm a speech therapist and lecturer at CUGH Health Sciences University. The research I'm presenting is part of my doctoral study and completed with the University of Pretoria in South Africa. This research paper explores children with severe acute malnutrition, feeding, swallowing, and communication characteristics. As the study was done during the COVID-19 pandemic, we noted some helpful insights about the effects of the pandemic on the healthcare system and ways that speech therapists might support children with malnutrition. So malnutrition includes both over and undernutrition. Severe acute malnutrition specifically is the most severe and life-threatening form of being underweight. According to the World Health Organization, severe acute malnutrition, or SAM, is diagnosed by three possible criteria. Firstly, the child's weight for height falls more than 3 standard deviations below the norm. Secondly, there might be presence of nutritional edema. And thirdly, a child aged 6 to 59 months may have a mid-upper arm circumference of less than 115 millimeters. Treatment of SAM in sub-Saharan Africa is complicated by concurrent infections of HIV and/or TB. A high prevalence of 40 to 50% is reported among children treated for SAM in South Africa. HIV is known to negatively impact mortality as well as nutritional recovery for children with SAM. Additionally, similar to SAM, HIV poses a risk for children's neurodevelopment and physical growth, which increases concern for our children's health and development. TB changes respiratory rate, it increases fatigue, and it increases the risk for oropharyngeal dysphagia, which is difficulty in swallowing. Concurrent HIV and TB co-infection significantly increases risk of mortality. And among all of this, we now add concerns for COVID-19, which is another respiratory illness. The research on SAM has developed from a medical focus on survival to prevention and now improving treatment outcomes. Timely medical intervention in South Africa, according to the World Health Organization 10-step guidelines, has reduced case fatality rates from 30 to 40% to less than 15%. However, recent research shows that survivors experience neurodevelopment disruption and long-term developmental outcomes show cognitive and motor delays. These delays have a negative impact on educational outcomes, future employment, and mental health. It is therefore important that we identify and address SAM early to prevent burden on the child, family, and the community. The COVID-19 pandemic further undermined the financial and nutritional support for families. Social distancing and fear reduced clinical attendance and monitoring for prevention of malnutrition, which exacerbates concerns for the well-being of our young children. We've established that cognitive and motor deficits exist, but there's no research on language development and oral sensory motor skills for speech and swallowing. We need detailed information to inform speech therapists how they can support this vulnerable population. We used an exploratory collective case study design to describe the swallowing, feeding, and communication characteristics of 3 toddlers with SAM during inpatient nutritional rehabilitation. These case studies form part of a larger study and were collected on the 16th of June during the COVID-19 pandemic. All cases that met the selection criteria and presented on the day at the tertiary hospital in Gauteng, South Africa were selected. At the hospital, they have a full multidisciplinary team with doctors, nursing staff, speech therapists, audiologists, dietitians, physiotherapists, occupational therapists, social workers, and psychologists. Treatment and management of children at the hospital closely follows the World Health Organization 10-step guidelines for SAM management. The dietitians assess and identify children with malnutrition in the pediatric wards daily. Our bedside assessments for data collection were conducted when the children were in the rehabilitation phase of nutritional SAM recovery. This means that they were no longer considered acutely ill with life-threatening risks. Our data collection included an interview, communication assessment with the Rossetti Infant Toddler Language Scales, and feeding assessment with a schedule for oral motor assessment, as well as additional considerations for aspiration and disruptive feeding behaviors. We identified 3 participants. Their mean age was 1 year 4 months, and all 3 participants presented with normal birth weight. They were all diagnosed with SAM, and unexpectedly, all 3 participants were also diagnosed with HIV and TB concurrently. All 3 participants showed psychosocial risk factors of informal housing, and despite monthly income levels above the lower bound poverty line, as well as the food poverty line, all mothers expressed regular food insecurity. The protective factors in their household was that there was no presence of substance abuse. This table shows significant medical information for all 3 cases. It is noteworthy that all mothers reported short breastfeeding duration. At the time of data collection, although speech therapy services are available at the hospital, none of these cases had been referred to the speech therapy department. For the results of the feeding assessment, we first highlight that mothers reported disruptive feeding behaviors in their interview. Most importantly, the toddlers were refusing to eat their food in the beginning and middle of meals, instead of at the end where it's expected they might be full. This high frequency of food refusal is consistent with SAM. Children 13 to 18 months old should be able to sit or stand independently to feed. However, 2 participants required support to sit to feed, which indicates inappropriate delayed motor control, and this is consistent with SAM symptoms. The toddlers should be able to eat all consistencies at their age. However, 2 participants had difficulties with puree and semi-solids, and another participant had difficulty with liquids, showing uncoordinated swallows, multiple swallows, anterior loss of milk, and panic reactions when milk was placed in the mouth. At their age, toddlers should self-feed with adequate lip closure and both lateral and vertical tongue movements, rotary chewing, and no food loss. However, study participants had oral sensory motor dysfunction in the oral preparatory phase that impacts their ability to take food and chew and swallow it safely. Difficulties with jaw opening, lingual control, bolus manipulation, and mastication chewing was observed, as well as poor lip closure. Although their pharyngeal swallows were adequate, a cough and wet vocalization were observed with 2 participants' assessments. This indicates that poor oral motor control and coordination in the oral preparatory phase may place children with SAM at risk for oropharyngeal dysphagia. Feeding difficulties can be exacerbated by respiratory symptoms and lethargy related to SAM, HIV, and TB, as well as the symptoms associated with COVID-19. Results of oropharyngeal dysphagia warrant dietary consistency modification for the prevention of prolonged nutritional recovery or even SAM relapse. When identifying cases for this research, it was unexpected to find that all 3 cases presented with both HIV and TB co-infection as well. The research took place during the COVID-19 pandemic, and so the following observations were also made. Short breastfeeding duration, PMTCT failure, poor adherence to baby wellness consultations, delayed diagnosis and onset of treatment for TB and HIV, only at hospital admission for SAM, are indicative of breakdown in public health service systems during the COVID-19 pandemic. The delayed identification perpetuates the quadruple burden of disease in South Africa and highlights the effect of socio-behavioral adaptations made for the COVID-19 pandemic. We need to keep this in mind for future practice. To close, I'm going to highlight the clinical implications for this research. Firstly, the complexity of SAM with concurrent HIV and TB co-infection highlights the need for effective teamwork. Novel description of oral sensory motor skills for feeding, risk for oropharyngeal dysphagia, and atypical communication development of 3 toddlers with SAM highlights the potential role for speech therapists in the SAM management team. Speech therapists could provide intervention before children are discharged to community-based management, and this might support the team efforts to improve SAM treatment and recovery, as well as prevent relapse. Going forward, speech therapists should be more aware of their potential role in this population, and we should work to develop further research to inform our role to help with intervention. PMTCT failure, poor adherence to baby wellness consultations, late diagnosis and delayed onset of both HIV and TB treatment in this research highlights the disruptive primary healthcare services during the pandemic. Going forward as healthcare professionals, we should be more aware of the effect of disruption to prevention and promotion services on the children's health and development, because we are their advocates. Please feel free to contact me if you have any questions. Thank you so much for listening. I really wish I was able to be there with you all. Have a good one.